Hey everyone, welcome to the Straight-Talk Physio Podcast. Your hosts are going to be Dr. Andrew Junak and Dr. Craig Giambattista. We decided to start this podcast because there's a lot of poor information going on in the medical field. We want to make sure that people get great healthcare advice, and it really does start at the very top, and then it trickles down to our patients. So I hope that you guys get a lot from this podcast. We want to tell you a little bit about ourselves before we get started on our first episode. And this episode, we're going to be talking about what does a physical therapist do. But before we get into that topic, we're going to have Craig kind of introduce himself. Craig, will you tell us a little bit about what you got going on?
Sure. So as you said, my name is Dr. Craig Giambattista. I'm an Ohio native, grew up in Youngstown, Ohio. I did my PT schooling down in Columbus at Ohio State, and kind of at the end part there is where I got connected with Drew. We were doing the same clinical together and kind of realized that we were both, big PT nerds. So we've kind of kept in contact ever since. I was lucky enough to do an orthopedic residency through the Cleveland Clinic. And after finishing that, I think you kind of hit the nail on the head with the rehab myths. We kind of had the chance to see enough stuff to kind of say that, this is some stuff I think that needs to be addressed. And it's pretty simple stuff too. So I think clearing that up can be really helpful. As far as work goes, I am a traveling physical therapist. So I take 3-month contracts all over the United States. Right now I'm in the Washington area. So go Pacific Northwest, hiking, skiing, all that other good stuff. So when I'm not talking PT, that's my main area of interest.
Awesome. Thanks, Craig. Yeah. To give you guys a little bit of background on me, obviously me and Craig, we go back a little bit. We did a clinical rotation together. We did our residency together. We stayed very, very close ever since then. And yeah, that's what got us into doing this podcast. But so my history, I got my doctorate of physical therapy from Walsh University. I did that exact same residency as Craig did with the Cleveland Clinic orthopedic program. And then from there, I took my first job at a small hospital down in Columbus, Ohio. I was there for about a year. The work environment just wasn't what I was hoping it to be. I took a second job down in Columbus, Ohio, at a much bigger hospital. Again, there were some changes that happened at that hospital that took me out of, or kind of started to take away my love for patient care. So I figured there's got to be a better way. There's got to be a better way to do this stuff. So I started my own practice, Peak Physiotherapy and Performance. I've been doing that for about the last 2 years. The practice continues to grow over in the Columbus area. I'm now opening my second location over in Blacklick, Ohio, with my original location being in Canal, Winchester, Ohio. So just looking to help, or the goal of this podcast is essentially to help people find their way through the healthcare system and find good health and wellness. So we're happy to be able to give that to you guys. So with that being said, let's get started. So what does a physical therapist do? I think the best place to start with this question is to go with, what we think physical therapists do. Because going through our schooling careers, there's always that question, even for physical therapists sometimes. Like, it's really hard for us to even decide, like, what is that we do? Our professional association, they go down the road of movement experts. But if you talk to 5 different physical therapists, you get 5 different answers. So go ahead, Craig. What do you think? I mean, what's your take on this?
Yeah. And I think that's a great thing to talk about because, sometimes I struggle with thinking about that as well. And you know what? I like to keep the definition kind of as simple as humanly possible. It's just, we are the pros at getting you moving better. And that could be kind of whatever it is. So I like to keep it short and sweet. I think as, PTs, there is kind of like that little bit of an identity crisis, like what exactly are we doing? So when patients come to me, it's basically the number one thing is if you have trouble moving in any way, my job is to get you moving better. And I think there's a distinction there. It doesn't always have to be pain-free or it doesn't have to be, normal. I think that people get caught up in that. I think improvement with the end goal of it being kind of perfect. So I don't know what you feel about that, but yeah, I'd love to hear your thoughts on it.
Yeah. Mine's actually evolved as I've kind of gone through school and things like that. When I first got out, I used to say like, oh, well, we use X, Y, and Z, dry needling and corrective exercise. We use all these other things to help, optimize your movement and make you feel better. But what I've really boiled it down to over probably the past 1 to 2 years of, kind of being on my own and helping people is really it's about, what we do is we help people get back to doing what they love. Whatever that may be, every single patient comes to me with different goals, different aspirations. Some people say, hey, I want to get back to gardening. Some people say, I want to get back to, hitting PRs in the gym. I can't deadlift anymore. I would love to have that back. So whatever really is the patient's goal is our goal. Whereas, when you look at other situations, sometimes, an intervention is being used, but a lot of times people will define our profession as some sort of intervention, like, oh, they're the guys that do exercise, or, oh, they're the guys that do, dry needling. But really at the end of the day, I like to say, a physical therapist's job is to get you back to doing essentially what you love.
Yeah. And I think that's the perfect definition. And I think it's a good segue to kind of talk about, like, if we are going to define it, like, how were we trained, like, what's this? Because the one big thing I'll get is people will say, well, you know what? I went to go see my doctor or my physician or a physician assistant, nurse practitioner, and they have like a pretty good understanding of like what it took to get there. And then when they ask me, they say, well, how long did it take you to be a physical therapist?
Right.
And then I kind of hit them with the, well, I have a doctorate, and everyone gives me the same look, like surprised, their eyes get a little big. They're like, oh, so you're a doctor. And it's like, well, yeah, it's a clinical doctorate, so we really are the experts in that stuff. So maybe you can speak a little bit to the journey of the PT degree, and maybe, how quickly, in my opinion, how quickly it went from, relatively low schooling to now, this high level of education. And I think that kind of puts us in a little bit of an identity crisis. I think we can circle back to that, but I'd love to hear your thoughts on, or a little bit of opinion on, where we came from, where we are now.
Yeah. I mean, when you really look back, I remember back in school, I took my first job, and this is kind of gonna be shocking for some people, but I took my first job as a technician. So what a technician does is they kind of go around, they might help a couple people with their exercises. They might put some hot packs on people, but really you can't deliver any skilled care as a technician. You're just kind of think of it as like a really good helper. But pretty much everybody that I worked with there, they had their bachelor's in physical therapy. So thinking about that, they had a 4-year degree in physical therapy. Now it's a doctorate. So now initially it started out as a bachelor's, so 4 years, then it transitioned to a master's, and then it transitioned to the doctorate. And I'd say this probably all happened within, what'd you say, Craig, the last 15 to 20 years?
Yeah. And I think in the medical world, that's pretty fast. I know, just like relatively speaking, as far as other professions are concerned, it moved quick. I think it moved quick. And I think that puts us in a weird spot, because it's not like, PTs with a bachelor's degree aren't providing bad care.
Right.
But I think now with the doctorate, you're just exposed to so much more. I think there could end up being such a gap in treatment theory, treatment philosophy, hands-on techniques, dry needling, cupping, you name it, and I think that's where we kind of get into that little bit of an identity crisis. And it's like, some physicians, other healthcare practitioners, and especially patients, they don't really know what kind of training we have. So I think it's important that we talk about that.
Yeah, absolutely. And, some of the big transitions or the reasons behind the transitions were, at the start, physical therapy was, again, looked at more as an intervention. Like, oh, here's a script, you're going to go get some physical therapy. But that's transitioning to now we're independent practitioners. It used to be you needed a script to go see a physical therapist. A physician actually had to write on a piece of paper a referral to a physical therapist. Now that's not even the case. Like at my practice, I've probably had 2 patients come in with a script for physical therapy in the last 1 to 2 years.
Mm-hmm.
So, it's really changed the way we practice, but with that we have more responsibility at the same time. With medical screening and making sure there's not more serious things going on with patients before we even intervene with them. So for me, that's why I do a lot of telephone consults right up front to make sure, is there trauma involved? Does somebody need an x-ray? Does somebody need to go see their physician first? Is this even a physical therapy problem? So yeah, absolutely. With that transition came more education, and then a need for us to be basically better at what we do.
Yeah. I agree with you 100%. And I think since we're doing the whole, myth busting a series here for anyone listening, I think it's important to realize, like what you just said, like you do not need a script from a physician every time to see a physical therapist. We are standalone providers. We are trained to say, like, you know what, this is not a problem that we can work with. Like, this is maybe who you should go see. Like, not only are we the movement experts, but we also have extensive training on knowing when we can't help. And I think that's just as important. So as far as, like, one big myth worth talking about today, it's you absolutely don't need a script to go see a physical therapist. We are standalone practitioners, and we do have that ability to kind of, is this appropriate here? Is this not appropriate? And I think that's an important distinction to make.
Yeah, for sure. Now, with that being said, I will say all physical therapy is in no way, shape, or form created equal.
Agreed.
So, like, and that's not necessarily based on someone who has a bachelor's versus a doctorate. So level of education doesn't necessarily mean like, oh, this is a bad type of physical therapy or this is a good type of physical therapy. Um, there are just some physical therapy, the way that physical therapy is being practiced is just not at a very high level. And, what we like to call this, when you and I get together, is we call this like old school PT. We want to talk about a little bit what old school PT is, because that's kind of the outdated way of doing things. It's definitely what our profession was mostly doing 10, 15 years ago. But we've really moved on from that. So do you want to just shed a little light on, what old school PT is, or what we always talk about?
Sure. No, absolutely. And this is not bashing,
No, in no way, shape, or form.
anything. It's just like, because in 20 years, someone could look back on this podcast and be like, listen to these two idiots talking about, best practice. So I think it's a ever changing and an evolving thing. So we'll describe it, to the best of our knowledge here. But I would say, the old school it tended to be a little bit more passive. Like getting a massage, putting an ice pack on there, putting a hot pack on there, putting like the electrical stim, that the pads that kind of give you that a little electrical shock, and kind of basic stretching, maybe some basic movement stuff. But I couldn't tell you how many times a patient will come in and say, you know what, I'm here for like a massage, or this area hurts. Like, I think it needs to be massaged, So when we talk old school PT, I think that's what people tend to think of, especially the older generation. My dad, for example, hurt his back when he was my age, way back when, and he was talking about his PT experience, and that's what it was. He said basic stretching, and they just put the e-stim and the hot pack on me, and forever from that point on, because he has not had physical therapy since, that's what he sees it as. So I think that, talking about that and saying, hey, like, it's way more movement based now is something that's worth talking about.
Even the idea of like bed rest. I mean, I know back when I, kind of first started, I kind of worked in a clinic where there's quite a bit of old school PT. And, I remember sitting back and thinking, a lot of these people, they're being told to like not do anything, and not necessarily by the physical therapist. Bed rest is like a physician order. Like, hey, don't lift, don't bend, don't move. You hurt your back. Like, holy cow. And, based on what we know today, if you do that, you're now prolonging your back pain, and you're probably going to put yourself into a chronic pain situation. So it's crazy the amount of the growth that we've had as a profession. But yeah, there are still some places where old school PT happens every single day. But new school PT is pretty much, I don't have ice packs in my clinic. I don't have heat in my clinic. I do a little bit of soft tissue work, but it's pretty minimal. Electrical stimulation, like, don't have a machine, don't want a machine, don't need a machine. A lot of it is movement based, some joint manipulation. Definitely exercise is the primary focus of treatment. And education is huge too, like just talking to patients and getting them to, better understand what's going on with their situation. So yeah, I mean, new school PT is quite a bit different, but it's good because we're moving forward. We're taking steps in the right direction.
Yeah, I agree. And I think you hit on something that I think that was super important, and that's the education component. A lot of times when I see patients, and I mean, we tend to work with, people of all ages. So there's a pretty good chance that we're going to see someone that's had PT in the past, and I think our job of kind of describing where we're going is going to be key to kind of clearing that up. And I kind of describe PT as it's kind of like working with an artist, like it's so different, like not everybody is going to like this type of art. Not everyone's going to like that type of art. It doesn't mean it's bad or it's good. Just
Exactly.
sometimes you got to find the right person for you. And I think that's something we just are constantly got to get better at.
Yeah.
But
It's funny because the patients that feel like they found the wrong person or found the right person. Like you can definitely tell because they tend to stick to one therapist and they just keep coming back, for every problem in the future.
no, I agree. And I think that's the way it should be. If we want to get to that, autonomous level, like not to sound like, overly progressive, but primary care physicians don't discharge their patients.
Right.
And I think that maybe, sometime in the future, we could kind of adopt that sort of model where it doesn't have to be, you have to only come when you're hurt kind of deal. That's a different topic, for a different day. But I think that's kind of the direction I would like to see things go. But just kind of moving on with all, like, we're talking about all this, advanced degree, like new school PT and all that other stuff. I guess it would be worth talking about, like, what's the secret sauce,
Yeah.
like what, like versus somebody else, like what makes us better. If we're talking exercise, if we're talking, joint manipulation, mobilization, like a big thing is I'll get is like, okay, you guys do so much exercise, like, why can't I go see a personal trainer? I'm
Right.
sure that's something that you've heard in the past. So,
All the
if
time.
you could talk to that, like, why do you think, like, what's the value of PT versus, let's say, like a really good personal trainer?
Yeah. And to be honest, our bread and butter, and I believe our secret sauce is really our assessment. I think that's what separates us from other providers or other professions. If you really look at the different services we provide, and we're going to go through some of those services a little bit later, some of the different things that physical therapists do. But if you really look at the services that we provide, there's people out there that are also providing those services, right? It's not like a surgeon where, from a surgeon standpoint, um, you know, not anybody can just go and provide surgery. Like that surgeon has to do that type of surgery. For our profession, there's other people that can carry out some of the services that we do, but really our bread and butter is the assessment. It's getting to know the pathology and having an idea of what is actually causing the patient's pain. Anybody can go and do a bunch of exercises. Anybody can do some cupping or some massage, but at the end of the day, it's figuring out the root cause of the problem, knowing how to identify it, and then exactly what journey to take that patient on to get them from pain to pain-free to back to doing what they love without any hiccups in between. What do you think?
Yeah, I mean, I would echo the same thing. I think the timing is important, or being selective, right? So like if your knee hurts, for example, like I could Google right now exercises for knee pain, right? And I'm going to get this laundry list of things to do, and like doing them all, it might, you probably would feel a little bit better,
Yeah.
but what if it doesn't completely fix you and you're like, what, this exercise thing isn't working? I think, like you said, the assessment, what really sets us apart is being able to say, like, what, this is the stuff you need to do. This is the stuff that you don't need to do. And that's where
Right.
all that special training comes in that you just don't get with other stuff. I think one of my little gripes, or one thing I tend to think about is, I think people view exercise and movement as like a simple intervention,
Yeah.
like a
Oh, so
surgeon
true.
can do like a joint injection, or they can give you like a fancy medication. And medically that sounds like involved, or like special or something like that, because it's not something that you can just go do on your own.
Yeah.
And I think that saying like, hey, like I can prescribe you exercise, like saying that is like, I don't know. I think that's hard for people to register, like it can be prescribed, my 800 milligram ibuprofen 3 times a day, for the next week, and people aren't going to miss it, because it's easy.
Absolutely.
You just take your medication and you kind of go on. Whereas like, I think, viewing exercise as a prescriptive thing, it just like, I think maybe society, like as a society, or as like people, we're just not like geared to think like that.
Right.
I think people think
Exactly.
like, what's so special about, lifting my leg this way or doing a specific exercise, whereas I think if people tend to view it like that, I think that's when people tend to be a little bit more successful. And I think that that's our ability to pick out, this is the movement, the prescribed movement, or activity modification that you need to do, that's, like I said, that's, I think, where we can provide the most value.
That's so true. I mean, you hit the nail on the head there. I do injury screenings a lot, where I'll kind of go into gyms and people will come up to me and, I'll take them through a quick assessment. I'll give them an idea what's going on. And then, a lot of times I'll ask them, like, where do you want to go from here? Like, do you want to get this problem patched up pretty quick? Do you want to try to DIY this? And I've noticed that a lot of the people who do try to DIY their injuries, they stick to YouTube. They might Google a diagnosis, or like I tell them what's going on. They might Google it or exercises for it. A lot of times they just end up coming back to see me. And the reason being is because there's a skill to what exercises and when to do those exercises. If you're doing them too early, it's just going to continue to inflame the tissue and make things worse. So there definitely is a timing. There definitely is a skill. There's a journey to this stuff. And like you said, sometimes it just looks so simple because people exercise every single day, but it really is a prescription. I am prescribing exercise at the end of each visit based on exactly what that person sitting in front of me needs at that very moment. So, no, you said it perfectly, Craig.
Yeah. And I think just to piggyback on that too, I think another part of our job that we tend to maybe not talk about too much is just like the education part.
Yeah.
Just knowing what to do and when to do it. I think people sometimes will come to physical therapy and they're like, all right, well, I'm going to get my 30, 40, 50, 60 minutes of exercise in, and I'm just going to forget about it, until
Right.
I come back the next time, and I think that a huge part of our job is teaching self-management. And that might be, some sort of activity change that you might have to follow for weeks, and that's like a pretty
Yeah.
tough thing to do, again, just kind of going back to our typical medical model, like as a whole, we just want to like do one quick thing and then, done.
Then be done.
So I think that can be part of a challenge of what we do, but also what I find one of the most interesting things is saying like, okay, my job isn't just to work with you while you're here. My job is to teach you how to stop this from happening in the future and making
Right.
a change that why this happened in the first place doesn't happen again. And I think that's one thing, again, going back to the old school PT, maybe that was advice that wasn't given, or it was like you said before, it's just like, you know what, just rest for a while and, fingers crossed, it'll kind of clear up. So
Yep.
I don't know if you can speak to any of that or the education piece, but I think as we start to move forward, we'll start to get a little more involved with that kind of stuff.
Yeah. I mean, from an education standpoint, I have this cool app on my computer where I can kind of take out and, take muscles and put muscles on certain areas, or take them off, or do the same thing with nerves. So education is a huge component of what I do. If I don't educate the patient and they don't know what aggravates their symptoms, or what things they should avoid, then they continue to kind of poke the bear over and over and over again.
Mm-hmm.
It just kind of keeps things inflamed, and it's really tough to heal. So you don't necessarily have to stop what you're doing. You just might have to change the way that you're doing what you're doing just a little bit, so that you can, make the best out of the current situation, and then give your body time to heal and recover.
Gotcha. And I think, that'd be a nice transition to talking about maybe some of the tools we use to get some of that stuff done. I think now, especially nowadays, with all the social media happening, and there's just so much information that we have access to, you see providers throwing out a bunch of fancy terms, dry needling, cupping, manipulation,
Stem cells,
stem cells, the PRP injections,
man,
there's like, if you
just
can
throw
think
them all
about
out
it,
there,
yeah, if you can think about it, like somebody is out there peddling this stuff,
Yeah.
And it's like, let me ask you this, as PTs, what do we do that you might see out in like this new wave of conservative management? Like what do we specialize in? What would you find appropriate for a PT to do?
To be honest, I think, from a research standpoint, and this is with anything, I think every single thing that you do as a medical provider should be founded in research. Patients are not experimental. We don't experiment on patients. So we start first and foremost with what the research and the evidence gives us. If the evidence gives us, backing to say that this is going to be helpful for a specific condition, once we've identified that condition, then I think it's safe for us to use that. Now, that being said, there are things that are more effective than others in treating certain conditions. So that's not for the patient to worry about. That's for us to worry about. But things that I use in my practice that have been supported by research, things that I think any PT should be using or could use. They don't have to use all of these, but I think these are all like fair game. I would say dry needling is definitely one approach that's great for short-term pain relief. Cupping therapy is great for short-term pain relief. If you're not using exercise in practice, to be honest, I don't know how you're getting long-term results. So I think exercise is probably the best thing we have for long-term tissue healing and making sure problems don't return. I think joint manipulation is also something that's great for short-term pain relief. Activity modification is definitely a super important key factor, as we talked about earlier. Trying to normalize movement as best we can. I think sometimes we get hung up in saying, well, when this shoulder blade moves a certain way, the other one doesn't do the exact same thing at the exact same time. This isn't always pathology, but sometimes it is related to pathology, and that's for us to sift through. So I think doing our best to normalize movement, but also realizing that people are individuals, and that asymmetries do occur in life. It's just part of life and how we're made. I think that's important. And then lastly, I also think pain education is another thing that's been founded in the research for us to be able to say, hey, we need to be talking to some of our patients about pain, especially if it's chronic and long-term and it's impacting a number of different areas within our lives. So I'd say, is there anything else you got to add to that, Craig?
I mean, I think you hit all the big ones there. And I think that it's just knowing that the big thing is just knowing that physical therapists can do it. There have been many times where I'll have a patient come in and I say, you know what, let's try hands-on technique. I think that maybe, manipulating the specific part of your spine might be helpful, and they look at me and they say, oh, well, you're not a chiropractor,
Right.
and that's happened so many times where it's kind of like, well, no, this is in our wheelhouse, like this is stuff we do. This is stuff we're trained to do. We're good at it. We're completely safe when we do it. So I think bringing some of those to light is kind of helpful, especially from a patient perspective, because then when you're going in there as a patient, listening to a podcast like this, maybe that puts people a little bit more at ease, because if you now go in with an expectation and all of a sudden, someone who you thought couldn't even put their hands on you is going to, crack your back, so to speak,
Right.
I think there's a little bit of apprehension there.
Oh, for sure.
And I think that could lead to a negative outcome. So I think realizing that physical therapists provide these services is important, and that physical therapists can actually specialize too.
Yeah.
So I think that would be a nice transition here. Just like physicians can go and do, their fellowship, their specialties, there's oncologists, there's internal medicine doctors, there's, PM&R doctors, there's, ENTs, all this other stuff. Physical therapists can specialize as well. So, what do you think? Do you think you can talk to any of those specialties, or we can talk about the ones we have, because we are orthopedic certified specialists, which is just one in the, the kind of long list of specialties PTs can get into. So I don't know if Andrew, if you want to kind of speak to some of those specialties, and then we could maybe talk about, what we know best.
Absolutely. So within physical therapy, there's so many specializations. Like for me to really label them all would be, there's just so many. But orthopedics is one. There's neurologic physical therapy. So they focus more on like neuro type of disorders. So people who may have ALS, or people suffering maybe right after a stroke, those sorts of things. Pelvic health or pelvic floor, women's health. That's another one where women who are having pelvic pain, or maybe they're pregnant and they're getting ready to deliver a baby, that's kind of who you would go see in the case of, someone who specializes in women's health. There's geriatrics, fellowships in a number of different areas, especially in some of the hands-on techniques that we do, and learning how to become more advanced and even more skilled at providing some of those hands-on techniques, like with manipulation and things like that. There's sports for on-field coverage. There's vestibular and dizziness, which is also something that, we'll have to do a deep dive in sometime, because we're both, we both treat vestibular conditions. And we have quite a bit of experience in that area as well. And then also pediatrics is a specialty. I mean, it goes on and on and on. But yeah, our specialties, we went through the orthopedic residency at the Cleveland Clinic. So Craig, do you want to tell us a little bit about what, I guess, that entailed, and why do a residency, and I guess what that means to like our listeners?
Sure. So just kind of cycling back to, the schooling, starting out with a bachelor's, now a master's, now a doctorate with, these advanced specializations. It kind of just, I would say the big thing is it just shows that, this is what we're interested in. When you go to PT school, for all the, patient listeners out there is, physical therapy school teaches you to be a generalist. So coming out of school, you could see physical therapists in, plenty of different settings, in a nursing home, in a hospital, like you said, on the field, in your standard outpatient clinic, working with, Olympic level athletes, you kind of name it. So as you can kind of understand, when you're in school, you have to learn to be able to do all those things. Right. So it's tough for you to kind of, gain like an expertise in like, your area. And that's no one's fault because, not everyone wants to do the same thing. So you got to understand in school, you're coming out as a generalist. So what we did is we both knew that our area of interest was in like more of the orthopedic outpatient setting. So we did a residency part-time through the Cleveland Clinic, which basically was just a little extra coursework. We did some extra mentoring. And then eventually you sit for a certification exam. If you pass the test and you get these credentials, basically what it is just saying like, hey, we're really interested in orthopedics. We want to become, the experts in this specific part
Yeah.
of physical therapy. So for any of those patients listening out there, it's just like seeing a doctor. With your basic problems, you see your PCP, but if they say, hey, this is, you need to see a specialist for that, like in a kind of a small way, PTs do have that. So I don't know what your thoughts are, Andrew, but that's kind of where I see it.
Yeah, absolutely. I think the benefits of a residency is it really does help accelerate your growth as a therapist. They kind of add a little bit more detail to that. The big boards exam that we would take at the end for specialty practice, you have to practice for, I believe it's 5 years, right, Craig? Before you can sit for it?
For the OCS?
Yeah.
I think it might be 5 years, or there's like, you have to have a certain number, like amount of hours of clinical experience before you're even like accepted
Right.
into it, or do a residency. So it's not like you can't just go out and take it kind of deal.
Exactly.
Yeah.
So like in our cases, we graduated, we went right into a residency. We interviewed, we went through a rigorous process to make sure we could get accepted. Financially, we also have to pay to do a residency. It's not like the typical physician model where they get paid to specialize, even though they get paid a small fraction of their salary. For us, we actually have to commit to that financially as well. And then when you go in and you do this residency, the goal is to be able to get patients better faster. So when you're set up with a mentor, you're matched with somebody who has a specialty in many different areas of theory or areas of practice. So I actually did one of my mentorships, or one of my times with mentorship. I know a lot of people know that I treat the jaw. I had 40 hours of patient care of working just with people who had jaw pain. So to give you an idea of how you can specialize, like think of how many cases of that I've seen within that 40 hours of treatment. Specialty cases, niche cases, surgical cases, to where if I was to see a patient with jaw pain, there's nothing new that I haven't seen before. So it just gives you so much more exposure. And then from there, you learn treatment techniques that other practitioners who are like, even they're subspecialists within their areas, you're learning techniques directly from them on how to get people better faster. So at the end of the day, you come out with this wealth of knowledge, and then you go into the clinic, you apply it, and then you start to get those more improved outcomes a lot faster than people may get just from a generalist physical therapist.
Yeah, I agree completely. And I think one thing that's worth noting, especially for listeners out there, is let's social media wise, let's get a link going to how you can find these practitioners, because that's the
Absolutely.
big thing. It's like, okay, like, you know what, I think after listening to this, like, I think I need a women's health specialist,
Right.
and I never knew that existed. And it's like, okay, great. How do I find them? So we'll link that in there, just kind of the website to say, you put your address, zip code, and whatever, and it's this is the person you want to see, kind of
Yep.
deal, or at least get you off to the right start, because I think that information isn't readily available. So we'll link that out for you.
And you know what? Maybe what we'll do for our viewers is maybe once in a while we'll bring in a guest who specializes in some of these different areas, and then you can learn a little bit more about kind of their specialties. Obviously, this podcast is going to focus on orthopedics, because that's our specialty. But we know that not everybody has orthopedic concerns. So what we'll try to do is diversify the podcast a little bit and maybe bring in some guests. What do you think, Craig?
I think it's a fantastic idea.
Fun. I guess, thinking about wrapping up here, I guess one of the biggest takeaways from this is, I think when you were talking about some of the things, like when people ask, you can do a manipulation, you can do exercise. You're not a personal trainer, but you do exercise. You're not a chiropractor, but you do manipulation or adjustments. You do dry needling. Like, what is it that you do? And I think, when we answer this question, or the biggest takeaway from this podcast is, you can't define us by doing a specific intervention, because when you really sit back and you think about, who uses like needles to treat things? Acupuncturists. Who uses cupping? Massage therapists. Who does exercise? Personal trainers. Who does, joint manipulation? Chiropractors. When you say, what does physical therapy do? And we kind of dabble in a little bit of everything. I think at the end of the day, the best definition of it is that we help people get back to doing what they love. And it doesn't matter how we do it. That's for us to worry about. It's not necessarily for the patient to worry about. That's for us to figure out. So at the end of the day, what are your thoughts on that? Like, it really, I think what separates us from other professions, and, when somebody asks me, what does a physical therapist do? I think it's our assessment that makes us different from other providers. And what it all boils down to is we help people get back to doing what they love. Any thoughts on that?
Yeah, no, I agree with you 100%. I think what makes us special is the ability to kind of assess movement. And I think that that's our number one. And I think the other stuff outside of that just tends to be the accessory to help improve that, whatever that might be. So I think down to the core, we share that, inherent value of being a movement specialist. And I think all that outside stuff that we talked about today is just, figuring out the best way to self-manage and improve movement and lead to better function. So I think that's where we're at. My advice, at least for, any patients out there listening, is just kind of pay attention to the old school versus new school physical therapy, and just keep an open mind. And I think just be ready to be active, and just be ready to make a change kind of as a whole. I think that's where people tend to fail a little bit, is like you said before, it is like a journey we got to go on. And I think if you kind of keep an open mind, and if you're ready for that, and if that's the way that you're thinking versus I'm just going in to get my massage, random stretching, and then I'll see you in a couple of days, then I think that's when, you'll tend to get a little bit of a bad outcome. So I would say if there was like a cap, like the one thing, if you didn't listen to anything until this last, 20 seconds, I would say just be ready to move frequently, and just make some whole life, whole person changes. And I think that you'll be way more successful than you think.
Yeah, absolutely. All right, man. Great episode today. Thank you for tuning into our podcast. If you like what you're hearing, please follow us on social media at Peak Physiotherapy and Performance on Facebook and on Instagram. The handle is at P3 Physiotherapy. We will also be on all the major podcast channels, so feel free to tune into us there. Thank you so much for listening, and have a great day.